It seems AI-related news is everywhere. OSF HealthCare added to the mix with several novel uses created by OSF innovation leaders and some of our academic partners. Dr. Jon Handler is a clinical informaticist and senior fellow of innovation at OSF HealthCare. He led the way by creating an artificial intelligence-based algorithm to better balance workloads by predicting upcoming work burdens for each cancer patient nurse navigator, both for their existing patients and for new patients. He joins us to talk about his work and how that actually got him some attention from the president as well. Thank you for being with us today, first of all. So let's start with a little bit about your background because it is quite impressive. You're an emergency medicine physician by training, as well as a clinical informaticist, which sounds like a very interesting combination to me. Tell me about your background.
Sure. I goes all the way back to when I was in college, and I just didn't know what I wanted to do. My mom was a nurse. My dad was a doctor. I thought being a doctor would be a great thing, help people and fun and interesting. But I also thought about going into business. I ended up doing some computer programming as part of my business degree, which I ultimately got in finance. But I ultimately became a doctor. I went to medical school. I didn't touch a computer again for 4 years. I then went to my emergency medicine residency out in Washington, D.C., and by pure luck, I stumbled upon a place where the world leaders in emergency medicine informatics were working at a time when, in the early 90s, nobody even knew what that word was, including me. But we did have a year that we could dedicate to specializing in some area of emergency medicine, in addition to our clinical work. And they invited me to join them in learning informatics. And so I did, and that really changed my life. At the end of the day, I became both a clinical informaticist and an emergency physician. I practiced at Northwestern, but also started the section of informatics there. I did a lot of informatics work. And then after almost 10 years of practice as an attending physician, I moved full-time into clinical informatics.
Had to be a little less hairy coming from emergency medicine just to clinical informatics, maybe a little less stressful?
It definitely was a big change, and there definitely was a lot less of that time crunch and the stress of the emergency department. I loved emergency medicine. It was very, very rewarding and gratifying to be able to help people. And I also saw this as another way to do it, and a way to help people more people than I could one at a time in the emergency department.
You are considered our go-to AI guy, if you will, and the predictive modeling using data. We come to you a lot to hear about that. So when the opening of the OSF Cancer Institute in Peoria came along, it just opened here in February. So let's talk a little bit about the pilot you did at OSF St. Francis Medical Center, working with the nurse navigators. And I guess we should start with explaining what a nurse navigator does and why that's important on the cancer journey.
Sure. Obviously, when somebody gets a cancer diagnosis or has the concern or there's the suspicion that they may have cancer, it can be terrifying for the patient. It can be very difficult to know now, what do I do as my next step? And there's obviously some urgency around that because you want to get your diagnosis and you want to get your treatment started right away, give the best chance possible. And the process can be difficult and it can be complex, and there's social issues to deal with. There can be economic issues to deal with. There's, of course, the clinical issues to deal with. Those all come together at a time that is very often very, very difficult and stressful for people. And so nurse navigators, or there are cancer navigators, and there's nurse navigators, and there's actually community-based navigators. But we have a nurse navigator team here at OSF. And the nurse navigators will help the patients through the process, help ensure that they understand what's going on. They help ensure that they get their appointments set up, that they get their diagnosis, that they get their treatment, and essentially help shepherd them through the entire process in a way that I hope is, and I believe, and has been studied and shown to be beneficial to patients, both in terms of how well they do clinically and how the overall experiences of getting their care, how that turns out for them.
So you collaborated with an academic partner to come up with an artificial intelligence-based algorithm that can predict the workload, that looks at the workload of these nurse navigators for the upcoming week. Why did you decide to tackle this project and do that?
When I first came to OSF, there was already some work that had started on this front. Our academic partner at University of Illinois College of Medicine in Peoria, we had a researcher there, Sarah Stewart D. Ramirez, a physician, and she had already started some work on cancer patient navigators and what can we do to facilitate their work. And when I came on board, I got to join in that work and ultimately we ended up taking it into this artificial intelligence space because when we talked to our cancer patient navigator lead and that team, we found that very often the cancer patient navigators, they're super dedicated. They're not going to turn any patient away. Unfortunately, there's a lot of patients who need cancer patient navigation. And if we don't turn them away, what that happens is people can get overwhelmed. And because we sometimes will have two cancer patient navigators handling the same types of patients, sometimes the work is lumpy. One cancer patient navigator will have more work in 1 week, and another will have a little less work. And so one is really overwhelmed and stressed while the other one is less stressed. But our cancer patient navigators want to maintain that relationship with the patient. So they won't just pass off their patients to somebody who's got less work.
Ownership.
Ownership. Yeah, they want to make sure that we have a relationship. We want to do the right thing and keep that relationship. And so what we realized was we could help them by when new patients come in, we could identify how much work the new patients are going to have, how much work are the cancer patient navigators each currently shouldering, and we thought we had a potential to use artificial intelligence, machine learning, to distribute new patients in a way that ultimately leads to more equality of work so that nobody, hopefully, is super stressed out at any one time. Nobody is overworked.
Yeah, it all comes down to data because your world is about data and taking it. So what kind of data did you have to input? Because you do have to input to come up with the information and for the outputs that you were looking for, both for current patients and then incoming. Because you're right, every type of cancer is different. Every patient is different. So what kind of data did you pull to come up with the algorithm?
Luckily, a lot of information is already input through the process of care. And of course, the more we know about a patient, the easier it is for us and the better of a prediction we can make about what kind of work they might need from the cancer patient navigator as we go forward. And so there's some patients on which our predictions are less accurate and some on which there'll be more because we have more or less data available to us. But we looked at a whole swath of data that we thought might help the algorithm to predict how much work the patient might need. Those would include a whole bunch of things. What is their age? Insurance. What is their insurance? Will they need help with that because there's economic issues? How far away do they live from different locations of care? Also, what is their burden of medical illness already? If you have a high burden of medical illness, you may have a more complex case when it comes to treatment. And what is your prior usage of your existing kind of usage of the healthcare system? Because if you already need to use the healthcare system a lot, then this is an added burden on top of that for the patient that we may have to help them with. And so a whole bunch of these factors, clinical factors, demographic factors, we put all those things together, and also what kind of cancer they have. There are some kind of cancers that require more or less intense treatment. So to the extent that we knew those things, we would put them into the model. And then once that was for new patients, and then we took the same information, and as we continue to follow the patients, we get more and more information so that we can get a better assessment of work that's coming from your existing set of patients you're already following, to help inform your total workload as we bring on new patients.
It just sounds exhausting all around. Okay, so this is a retrospective simulation study. So we're not live, if you will. So first of all, explain how that works and then how you tested the algorithm to see if it was doing what you kind of thought it would do or what you were finding out.
So we have an enterprise data warehouse, and it's a repository of our historical data that we can access to do work such as helping to improve the quality of care that we provide, and also to do work like this research. And what we did was we created the model, built it off of the historical data, and then we applied it to a set of historical data and said, let's take each patient as they come in and let's pretend like we're assigning them to a cancer patient navigator. They did get assigned to one, but now let's pretend that we assign them, and we'll try assigning them in two different ways. The way our cancer patient navigators do it today, it's almost random. They pretty much do, you get one, I get one, you get one, I get one, you get one, I get one.
Regardless of the cancer, regardless of the demos, regardless of anything.
Regardless of anything.
Okay.
It's not perfectly like that. If we're splitting them and you're super duper overwhelmed, I might say, I'll just take two in a row. But for the most part, it's back and forth and not taking into account the patient's, all that other information.
All that other stuff, yeah.
So we said, fine. What we're going to do is we're going to run in the simulation one way, looking at the actual patients that we saw and the actual historical data, and we're going to run it as close as we can to what they really do today. We're just going to randomly assign it from one to the other. And then we're going to compare that to saying, instead of randomly assigning it to one to the other, as the new we're going to go patient by patient, and as they come in, we're going to let the model decide who should get each patient. Whether there's 2 cancer patient navigators or 3 cancer patient navigators, we're going to distribute them. And then we're going to look back and see each week, how fair was it? Were there weeks where one navigator was way overwhelmed and the other one had very little to do? Or did it look like it was more even? And what we found was that in the random one, there were many weeks where the navigators would get very overwhelmed or have a much higher workload. And when we used the algorithm, in most cases, we were statistically significantly more fair in terms of the workload distribution.
Did that surprise you?
It did and it didn't.
Okay.
The reason why it didn't surprise me was because I felt like the model should be able to do better. And at the same time, you are trying to predict the future. Very often we have very little information, and it was a difficult challenge. In fact, even just figuring out what is work and how much work do they do, we had to create a lot of we call it proxies. We had to guess how much work each patient would do and find things that indicate how much work a cancer patient navigator had to do on each patient in order to even measure our results. All that was really, really difficult. There was a large part of the project where I wasn't sure we were going to succeed. I thought we might have to go back and tell our folks we tried and we couldn't do it. But ultimately, we did manage to muddle our way through. And yes, I was gratified to see that it looked like we had the potential to make a difference.
How long? I mean, as I'm listening to you describe this and the inputting and the collecting of data, what was the length of this? What's time period are we talking here?
It was about a year-long project. It was a grant-funded project from ARCHES, which is a grant funding agency, a collaboration between the University of Illinois at Urbana-Champaign and OSF. And that project lasted a year. I'm pretty sure we were pretty close to within the year. We may have actually, now that I think about it, we may have actually gotten an extension and taken it out to a year and a half. It was a lot of work.
Yeah, it sounds like it was a lot of work, but isn't that the idea? You do this work to help hopefully reduce, which it sounds like it will lead to perhaps a reduction in burden moving forward once we implement that, which I want to get to that in just a second. One of the things we hear about with AI and algorithms is the potential for biases and health equity. How do you guard against that in something like this so that you don't, or is it just completely randomized and you don't know? But is there a way to safeguard against any biases that could creep into some of the data?
There are ways to safeguard against that. One is to try and use a data set that itself is unbiased, but that's, humanity has biases. And so the data itself comes from humanity. It's impossible to get a perfectly unbiased data set. But number one is the underlying data itself. Number two is what are the input features that you put into it. So do you and there's a lot of discussion about this. What are the data inputs that you put in? If you put in things about different demographic populations, if you give the model that information, does that increase or decrease the likelihood of bias? There is some question about that, and that answer may differ depending on what you're trying to do and your data. I think at the end of the day, the ultimate expression of this is to actually go back and, after you've got a model, to go back and look and see, did it perform differently for one group versus another. It may be a little bit less relevant here because we were just trying to evenly distribute patients. We weren't selecting which patients were going to get care or not get care. They're all going to get care. But we did, for example, do a study that we published on predicting near-term mortality for patients so that we could help inform end-of-life care and decisions. And we did very specifically think very hard about and specifically looked at and studied the equity and fairness of that model in a variety of different demographics and populations. We were gratified to see that it appeared to be a fair model, and we published our results on that.
Which, like you said, is always gratifying to see. So let's talk about the feedback you're getting. You finished this project off for the nurse navigators. It was a retrospective simulation study. So what kind of feedback do you get? And then what is the next phase for this and implementing it?
So we have a model that, based on our data, suggests that it will be fairer. And that it will more evenly distribute the work, and that at the end of the day, our cancer patient navigators will be happy and satisfied with that, more so than they are already today with their current method of distributing patients. The only real way to know that is to actually put that model into practice and see. Even if the model distributes the patients more evenly or fairly, what really matters is, what do the patient navigators think of it? So one, does it do what it says it would do? And which is distribute the patients more fairly. That's question number one. Right. We think it probably will, but the proof is in the pudding. The second one is, when we do that, does it create the outcome that we want, which is really, at the end of the day, a human outcome. And so we're busy now actually implementing the model. We're technically putting into place, making the modifications to the algorithm and how we actually implement it so that they can see the results and they can act on those results. And then we're going to put it into place for one set of patient navigators for one kind of cancer. Study it. If it looks like this was a great thing, then we'll expand it to more types of patient navigators and then maybe to other hospitals in our system.
So it's kind of baby steps. Is that, I'm sure part of your brain is going, we just want to do this. And the other part's like, no, slow and steady wins the race. Is that kind of where you're at right now?
It is. You have to force upon yourself, I think, as a researcher, some humility that the stuff that works in theory doesn't always work in practice. The stuff that worked on a retrospective data set doesn't always work when you do it prospectively in the real environment. And what worked yesterday doesn't always work today because the environment changes. And so I think we want to move fast and we want to move deliberately. So hopefully we can take fast baby steps, but careful, fast, thoughtful baby steps.
Is there a time frame? You said you're starting to implement. So is that physically doing that, or are we still a little bit from that? Are we there and we're starting to implement it?
So we are just as we speak. I have an email that on our one of our analyst programmers that works together with me is actually going to start that work within the next day or two to begin putting the final implementation together. and then we'll release it. So I'm hoping very soon.
Maybe by summer. Maybe by
wonderful.
summer we'll be doing something that we'll see it going along. Because you're right, time frames you think, and it always takes a little time. But the potential, it sounds like, as well, if it proves successful as the hope is, could there be some commercialization of this down the road for other locations and types of providers to use this?
I think there's always the potential for that. There are many different types of cancer patient navigator systems. There's the community-based ones, there's the nurse-based ones. There's some that use specialized nurse navigators that specialize in specific types of cancer. So a few for each type of major kind of category of cancer. And there's some that are more generalized. One covers all types of cancer. There's different sizes of programs. So, and some programs may not even have cancer patient navigators, and some don't. So I think there's the potential that creates both a challenge and an opportunity. The challenge is, if you were to commercialize it, how would you make it customizable in function for all these different kinds of systems? And if you solve that issue, then I think you have the potential for something that could be commercial success, and importantly, a commercial success that creates benefit for patients more broadly. At the end of the day, the reason to commercialize something, a compelling reason to commercialize something, is to have a sustainable model to get benefit to patients in the hands of those who can deliver it.
Okay, we're going to switch gears now. In November, you spent 2 days participating with other experts in a discussion of technology supporting cancer patient navigation. It was a panel advising the President of the United States, just tossing names around there. Okay, so how did that come about? And do you think it had to do with your published paper on the AI navigation project? Do you think there was a connect there? Or tell me what that's like when you get contacted by a presidential panel saying, "Hello, Dr. Handler, we would like you to be involved." What was that like?
An email just shows up in my inbox, the president's panel. And my first thought is, which president? The president of our hospital, the president of some institution? Yeah, I thought, it can't be the president of the United States president. I had to go down and do multiple checks to see that this was legitimate. And this was, in fact, a panel of the president of the United States. So once I understood and believed that was actually what it was, it was, I felt really great that somebody thought to ask me. I don't know, of course, exactly why. I assumed that this worked because it was such a close fit with what they were doing. May have played a role in terms of them choosing to invite me. There also was a second piece of work that we did. I got to play a role in another one that Dr. D. Ramirez had led, and I helped with the analytics on this. We did an intervention on screening for women who were late in getting their breast cancer screening. And we had done some work. When I say we, I mean the rest of the team had done this work, and I just got to help a little bit. But I'm going to say we anyway because it's easier. So had recognized that there were some inequities in terms of breast cancer screening, and that socioeconomically disadvantaged women were often less likely to get their cancer screening or to be late in their cancer screening. And so this study looked at, can we do interventions that would, number one, reduce the inequities, and number two, raise the boat for everybody, right? Help everyone to get more screening. And so we did 3 interventions to reach out and help women get more breast cancer screening. And we found that we could reduce and even reverse the inequities. We found that we could increase the boat as all ships rise. We found that we could improve breast cancer screening for all women with these interventions. And that was a really great. In fact, we literally doubled the breast cancer screening rates for the women who were late in getting their breast cancer screening by our definition of late. And so that was work number 1. And then there was work number 2 specifically in the cancer patient navigator technology space. And this was this was a panel on technology in cancer patient navigation and equity. So it really covered the bases of those 2 studies. I have to guess that those 2 played a role in the invite.
So what kind of input did you give? First of all, tell me because this was we were still in the virtual days and bringing that whole group together. First of all, who is on the screen with you that you're looking at and some of the names? And then what kind of conversations did you have and what kind of input did you give?
They had gathered really a very impressive list of people who were experts in many domains that related, people who were experts in the area of equity in healthcare, people who were experts in the area of cancer in general from some of the finest institutions in the country, people from industry, people and especially in the technology industry, but also generally in healthcare, and folks who were specialists in cancer patient navigation. So they really got a broad swath of folks who would be experts in the domains in which they wanted to focus. And so it was both a little intimidating and also wonderful to be with a group of people who were so dedicated to this area and who had such knowledge and expertise to bring to the table. We talked about a number of things in terms of what are the pros and cons of technology. Mm-hmm. What are the potential downsides and how do we avoid them? We talked a lot about bias. We talked a lot about how do we maintain equity? How do we use technology it can be used in ways that promote inequity. It can be used to ways that help reduce inequity. And how do we get to reduce the inequity part? How do we get better care for patients? It really covered the gamut of that content. It was a 2-day session.
Your work is in AI. Your focus is in that. Do you feel, especially the social drivers of health, as you said, that's been a large portion of the discussion. Do you feel we can get there, that AI can help even things out and potentially really make a difference when it comes to the cancer care that some patients are receiving? Because let's be honest, we serve a very rural population with OSF HealthCare. That's tough. Yes, we've opened the Cancer Institute in Peoria, but you still got to get there and you still got to get to the doctors and you still have to access care. Do you see AI helping that and us getting there eventually where it can make a real positive impact?
I really do. And of course, I come to you as a technology optimist, so I'm going to say that I think there's an opportunity there. But I think we have seen this in virtually every industry, that technology, virtual care, artificial intelligence has allowed us to be more efficient, which creates more capacity for a system that is currently overwhelmed. We have a shortage of physicians. How are we going to address that? And I think technology helping us to address that capacity, like our ability to better distribute the workloads, will help us to improve access to care. I think technology has also, in many other domains, has also shown that we can deliver service to folks who are farther away from us physically, or to folks who maybe don't have access to care. We've seen that during the pandemic. I think OSF was a leader in this space, in which we had folks out in the rural communities and in disadvantaged communities and elsewhere who needed care, who needed pulse oximeters, who had to deal with this overwhelming pandemic. And I think we used people, process, and technology together to help deliver great care and help ensure that our communities were safe and healthy during the worst pandemic we've had in 100 years. And I think that's just one. In telehealth, artificial intelligence, algorithms, these were things that help us to get there. And I think that's the kind of thing that we can bring to bear on cancer as well.
Your passion is evident as we have this conversation. What lies ahead for you, both with this project and for other projects? What's next on the horizon that we should be keeping our eyes and ears out for? Well,
we have these large language models, this generative AI, ChatGPT that everybody knows, and it's and others that are out there now. It looks to me like a new world. There's been a lot of hype in artificial intelligence, in healthcare and healthcare technology. And most of the time, I'm rolling my eyes at this stuff because we've been there, done that. We've seen this before. We've seen this story before. I think anybody who's actually put their hands on and used any of these generative AI technologies is shocked at the capability that we're seeing. And there's a little bit of a genie in the bottle thing, like the genie's out of the bottle now, and there's both, again, pros and cons that we're going to have to address. And at the same time, I think as we look to the future, there's a future that looks very exciting to me, in which we have a new set of technologies coming out and rapidly getting better that look like they have a real potential to help us deliver better care to more people in the best possible way and to provide the best possible service to everybody.
Okay, back in my head. So I think maybe later this year I'll have to have you back, maybe toward the end of the year, because I want to see how the implementation of the Cancer Navigator project goes and see if it's lived up to where you think it will live up to. It's an exciting thing to look forward to, because if it does, burnout is such a huge issue for physicians and for caregivers and for navigators across health systems. And you're right, to see where it goes and what we can do with it will be exciting. So I'll have to hold you to that and bring you back, and we'll have that follow-up conversation.
That sounds great. I look forward to it.
Dr. Jonathan Handler, thank you so much for being with us today for this very interesting conversation.
Thanks for having me.
Thank you for joining us for this edition of Health Accelerated, brought to you by OSF HealthCare. Listen and subscribe on your favorite podcast app. You can also find links to any of our episodes at osfinnovation.org/healthaccelerated.